finish my talks by talking about the controversies in fluid management. Somehow, I don't know why, but I'm always at the center of controversy. And it's just the way it is for me. But I appreciate it. And I like to argue because I'm from New York City. So it's good for me. I have the same disclosures, nothing new. So I want to talk a little bit about fluid resuscitation in 2023. And I want to do it by talking a little bit about where have we been, where are we now, and where are we going? So where have we been? This is very interesting. This is Manny Rivers' trial on early goal-directed therapy that was published in 2001. So it's not that long ago. It's less than 20 years, maybe 20 years ago. And what I want to point out is this is the amount of fluids that Manny Rivers used. This is in the first 6 hours. This is the total in the first 3 days. And look at the amounts. This is in the first 6 hours, he gave almost 5 liters of fluid. And within the first 3 days, he gave 13 liters of fluid. And this is published in the New England Journal. So none of us in the first 3 days, unless you're a surgeon, would give 13 liters of fluid, right? We often, we do ECMO in my unit, and it's not uncommon for patients to come down from either the surgical ICU or the trauma ICU, and they're 20 liters positive, which we know, and it's a very different world because patients who are post-operative and trauma patients often need more fluids. I'm not sure about 20 liters, but what's interesting is this was published in the New England Journal and 13 liters of fluid in the first 3 days, 72 hours. So we've certainly changed. Now, these are the 3, and I know you know this, but these are the 3, in response to the Manny Rivers paper, these are the 3 large randomized controlled trials that were done in the United States was Process, in the United Kingdom was Promise, and in Australia and New Zealand was Arise. And these 3 papers together all were negative, as you know. And what's interesting is this is from the patient level meta-analysis. So before the 3 trials were done, the investigators got together and planned to do a patient level meta-analysis. So this means that all of the inclusion criteria were the same for all 3 trials, which allowed them to combine all 3 trials and do another analysis. The thing that I want to point out that's really important, and this is partly why in the Surviving Sepsis campaign, we changed our recommendation to 30 cc's per kilogram, because prior to randomization, in all 3 trials, the average amount of fluid, the median amount of fluid was 27 to 30 cc's per kilogram. And so that's when we changed our recommendation. So again, I want to emphasize, and this is going to come up with the Clovers trial in a moment, but you can see that in the 3 large trials evaluating early goal-directed therapy, they gave about 30 cc's per kilogram. Now, the interesting thing to remember about Manny's data is he was double boarded in emergency medicine and in critical care. So Manny entered all of these patients in the trial as soon as they walked in the door. So for many people, their central venous oxygen saturation was below 60. So of course, it makes sense that then if what you do is before you randomize them, they get about 30 cc's per kilogram, of course, this trial is negative. It's not rocket science, as I like to say. But nonetheless, it's important to remember that we don't use early goal-directed therapy anymore, because often by the time we see these people in the intensive care unit, they've already received the same as this trial, about 30 cc's per kilogram. So the question is, where are we now? This is where we were, and I took you through Manny Rivers' data, and I want to talk a little bit about where we are now. As you know, this is the 5 iterations of the Surviving Sepsis Campaign guidelines, and we still recommend 30 cc's per kilogram. This is from the 2021 Surviving Sepsis Campaign guidelines, and we still recommend 30 cc's per kilogram, in part because of the PRISM trial, the 3 large randomized controlled trials that before they were randomized, they wound up getting 30 cc's per kilogram. So this is the Clovers trial, which was published in the New England Journal, and I think it was published last year. It was 2023, yeah, 2023. And this is a randomized controlled trial that was done by what used to be known as the ARDSnet, and it is now called the PEDAL network. And they're the ones who first developed the low tidal volume strategy. So this is a group of very, very smart investigators with great experience in clinical trials. It was targeted for over 2,300 patients. Unfortunately, it was stopped at the second interim analysis because of futility. So they had rules for stopping if there was demonstration of benefit or harm, and there are always rules, especially in a large randomized controlled trial, to stop if there's at each of the analyses, if there's no possibility of demonstrating a positive signal. So that's futility. And only 1,500, a little over 1,500 patients were enrolled at that time at the second interim analysis. And these were patients with sepsis, septic patients with refractory hypotension after 2 liters of resuscitation. And you see here, I don't know if you can really see this, but these are the two protocols. The one on the left is the restrictive protocol, and the one on the right is the liberal protocol. And what's unfortunate, and I'm going to show you a slide of this in a moment, is the assumption by many of us is that in the restrictive arm, they started with 1 liter of fluids and then waited to see and only gave more fluids if they needed it. And in the liberal arm, you could give as much fluid as you want. What's interesting, and this is really important, and it's not that well known, is it was in the first 24 hours prior to randomization and after randomization, the restrictive group got 3.3 liters of fluid. That's really important. 3.3 liters of fluid. And in the liberal arm, it was 5.5 liters. So when you think about it, restrictive fluids for us, you don't really think of more than 3 liters as being restrictive. And yet, and we just recently confirmed this because we're writing another paper. Writing another paper, and we just submitted it to the New England Journal. And we called Nate Shapiro, who is the lead for the Clovers trial, and he confirmed that, in fact, the restrictive arm within the first 24 hours got 3.3 liters of fluid, and the liberal arm got 5.5 liters. So this is suddenly, it changes your idea of this negative study, because, as I keep saying, none of us think of 3.3 liters as restrictive. And yet, this is what the restrictive arm got. So again, I'm not making this up. This is just the way it was. And we asked and found this out. So, and as you know, the primary outcome, which was all-cause mortality at day 90, and the secondary outcomes you see here, organ failure-free days in terms of being free from vasopressors, um, continuous renal replacement therapies, and ventilator-free days. And they looked at ICU days and hospital days. And again, the target was over 2,300 patients, and they stopped early after a little more than 1,500 patients. So this is the table from the New England Journal. And I want to emphasize this again, because on this table, it looks like the restrictive group got a little bit about 500 cc's of fluid, but in fact, they got 3.3 liters of fluid. So I keep saying this over and over again, because if you look at the paper, it's only when you talk to the investigators that you find out that within the first 24 hours, the restrictive group got over 3 liters of fluid. But yet on the table, it doesn't appear that way. And you can see that in the liberal group, they got 2,300 according to this table. And yet the reality is the restrictive group got over 3 liters and the liberal group got over 5 liters of fluid. So again, very different picture than you see. Here's the other thing I want to emphasize. This is called a restrictive trial, a restrictive fluid trial. But what it also is, and many of us practice this way now, it's not only restrictive fluids, but it's also early vasopressors. Now, we talked about this the other day, which is that for many people, you don't leave people hypotensive while you're resuscitating them. So, but in this trial, you can see the difference. Look at the difference. Oh, wait, one more. Oops. Look at the difference of the time from randomization. I guess not. Oh, there we go. The time from randomization to the vasopressors is 1.6 hours versus 1.2 hours, 1.8 versus 1.2. So in the restrictive group, they had earlier use of vasopressor therapy, and that was statistically significant. Very important. So it's not just restrictive fluids, but it's also early vasopressors. And that's really, I don't think there's any problem with that, but it's important to recognize that even after over 3 liters, these folks had earlier vasopressors and the concept of restrictive. And you can see here that for all secondary outcomes, the outcomes were negative. Again, it was powered for over 2,300 patients, and only 1,500 patients were entered. And so clearly, it's not surprising that the secondary outcomes would be negative as well. This is a trial that we published in 2019, and we did this at Brown University, and it was very similar. So if you look at the amount of fluids, and this also is my way of saying this is where we are now. So in the first, prior to randomization, these folks got over 30 cc's per kilogram, needless to say. But post randomization, there was enough of a split that was statistically significant. And you could see here 23 liters versus 37 liters. And we actually limited the amount of fluids in the restrictive group to 60 cc's per kilogram. And we were able to get that through the IRB. So we decided to limit the total amount of fluids to 60 cc's per kilogram, which probably for the restrictive group in the Clovers trial, 3.3 liters is probably close to 30 to 60 cc's per kilogram. Whereas the liberal group that received 5.5 liters was more like 60 cc's per kilogram. So this trial is consistent with the Clovers trial. And like the Clovers trial, we found no difference in outcomes, both the primary outcome of 28-day all-cause mortality and the secondary outcomes of renal replacement therapy, et cetera. So here are two trials that really demonstrate where we are now, which is the campaign still recommends giving 30 cc's per kilogram to a hypotensive patient who presents with sepsis. And that is apparently exactly what the restrictive group in the Clovers trial received as well. And it's definitely what our trial demonstrated. So 30 cc's per kilogram has been proven to be effective in both the Clovers trial and our trial, which was published in Critical Care Medicine. So the big question next, which is, after you give 30 cc's per kilogram, what do we do now? And that's, I wish I could tell you the best thing to do. Everybody has their own favorite hemodynamic monitoring. So you see here, some people still use CVP as CVO2. They wait till the lactate clears. They use PICO, which is a pulse pressure that is very popular in France. Pulse pressure variation, also developed in France by Jean-Louis Taboul. Esophageal Doppler, which is very popular in the United Kingdom. Almost everybody has an esophageal Doppler dropped dropped into their esophagus, and that's how they monitor cardiac output. IVC ultrasound is what we use to assess volume responsiveness. NICOM and FlowTrack are two proprietary instruments that I honestly don't know enough about to talk about. But I think the point is, what do we do after we give 30 cc's per kilogram? So I'm going to say it again, but in the Clovers trial, 3.3 liters is almost certainly 30 cc's per kilogram for an ideal body weight. And the same thing in our trial. And the question is, now what? And part of the issue is, I hope no one has seizures out there. So part of the issue is, we know that there's ongoing increased vascular permeability, even within the first 24 hours. So after you've given 30 cc's per kilogram, now what do? In the Surviving Sepsis campaign, we recommend, after the initial 30 cc's per kilogram bolus, to begin to use dynamic measurements, and these are all dynamic measurements, of some way of assessing volume responsiveness. Some people use passive leg raising with one of these forms of monitoring to monitor cardiac index response to passive leg raising. I think what I want to emphasize with this slide is there's no proven benefit of one high hemodynamic monitoring more than the other. And it really is a matter of whatever your favorite hemodynamic monitoring is, you should feel comfortable utilizing it. The problem is, and I know you all know this, is there are a lot of data that suggest that total fluid balance is associated with increased mortality. And this is the big challenge. And what I want to emphasize is the total fluid balance is very different than 30 cc's per kilogram, totally separate. So a fluid balance at the end of someone's hospital stay or intensive care unit stay is very different than 30 cc's per kilogram. So let's look at some of these data. This was published in 2011. This is Jim Russell's group from Vancouver in Canada. And he was able to show, he divided the total fluid balance into quartiles. So the quartile 1 was dry, and then up to quartile 4 were patients who had very positive fluid balances. And you can see that in quartile 4, their total fluid balance was closer to what Manny Rivers was, which was 10 liters. And in the dry quartile, it's 3,000 cc's. So I'm going to say this again because it's so important. 2,900 cc's in the first 12 hours is exactly what the restrictive group in Clovers received. So it's interesting that they're labeling this as dry when actually it's about the same in the first 12 hours as the restrictive group in Clovers. So we don't usually think of 2,900 cc's as dry or restrictive, but it is essentially 30 cc's per kilogram. So I'm trying to point out that despite all the controversy about the recommendations of the Surviving Sepsis Campaign, almost all of these groups, even when they're termed restrictive, are in fact 30 cc's per kilogram. And that's very important. Now, none of us probably would give 10 liters in the first 12 hours, again, unless you're a surgeon. But and you can see by day 4, look at the numbers. This is 30 liters of fluid, 16 liters. So I think even for a patient who's sepsis, and we go through this challenge all the time, I often come on rounds in the morning and find that my house staff, my residents, and sometimes the fellows, because someone got more hypotensive at night, they give them another liter of fluids. And that's how this works. So I want to emphasize again that you continue to have a vascular leak even after 12, 24, 72 hours. And if you keep chasing people's hypotension with fluids, you wind up with 30 liters over 4 days. And yet, in this trial that was published by Jim Russell, you can see that the highest quartile had a lower survival rate than the first 2 quartiles. So really good evidence that the more fluid you get, and remember, I showed you this was 10 liters in the first 12 hours. It's not that much, but it goes back to the old days of where we came from rather than the current thinking. So this is another trial. This was published from the Mayo Clinic, and this was published in 2015. And you can see here, this is the more increased mortality rate in patients who had evidence of consistent fluid overload as diagnosed by ultrasound and chest x-ray. So again, evidence of, and this was, this was total fluid balance in 1 day, which was 5 liters fluid balance. And this was over the first 3 days, which was about 6,300. And this is fluids received in the first day, which was about 4,500 cc's, and the admit dry weight. So again, evidence that when we drown people by continuing to chase them with fluids, if they have persistent hypotension, then we pay the price with mortality. This is from the FACT trial, which was also by the ARDSNet at that time. This is the trial that looked at monitoring CVP versus pulmonary artery wedge pressure with a PA catheter. And you can see here, this is a number of fluid boluses, and you could see that there were about 569 fluid boluses, and fluid boluses per patient were almost 5. This is in the overall groups, and the time interval was about every 3 hours. These folks got fluid. So again, I go back to how much our practice patterns have changed, because in this trial, this was published in 2015, but the trial itself was done in 2012. So you can see that our pattern of behavior at the bedside has really changed. And you can see this is because this was how many patients were in shock, how many patients had a low wedge pressure, and this is the boluses. Look how few patients had more than a 15% increase in cardiac index. It was only 23 out of the 569 patients who received a fluid bolus. Also from this trial, you can see that really the bottom line is there was an increase in heart rate, there was a mild increase in cardiac index, and a mild increase in wedge pressure, 1.7 is not that big an increase. So, and you can see that the cardiac index, and I showed you on a previous slide that the percentage of times that it led to more than 15% increase in cardiac index, and you look at the percent of time that the cardiac index is 0.16, and the average was actually negative. And this was statistically significant. Both these two were. So yes, the wedge pressure went up. The cardiac index barely went up. And this was also important data. This is more data from shock from 2015. Oh, actually, I just showed you the slide. Sorry about that. Yeah, this is the quartiles that this was done by Marin Koloff from the United States in St. Louis. And he looked at minimizing fluids. And this was a pilot trial. And he was able to demonstrate that you see here in the intervention arm, and there was really no difference between, and this is the important thing to remember here. If you look at on day 3, the total fluid balance was 4 liters versus 4.4 liters. So even in the restrictive fluid group, which was the intervention group, versus the control arm, our practice patterns are such that everybody gets 30 cc's per kilogram. And that's the reason, again, I wanted to show you this slide. So, and you see here, there was no difference as you would expect, because there was no difference in fluid resuscitation, that there was no difference in the secondary outcomes. So what do we do now? I've just shown you data that essentially 30 cc's per kilogram is still the standard of care. I showed you some evidence that the more fluid we give, the worse patients' outcomes are. And when we've done trials that try to restrict fluids, they still wind up getting close to 30 cc's per kilogram. So I think we have to start with 30 cc's per kilogram. That's certainly the recommendation. But the question is, what's our endpoint? And then how long do we continue to look at fluid responsiveness? And I think that's the key question, because as I said earlier, if we look in the first 24 and 72 hours, we'll see leakage in a way that will challenge us to give more fluids. And yet the evidence is that if you continue giving fluids, patients do worse. So where are we going? And the problem is, I'm not sure where we're going. This is a trial. This is the FRESH trial. This is from Australia and New Zealand. The protocol was published in 2017, and we've yet to see the results of this trial. It's Australia and New Zealand, and so they're likely to enroll almost 5,000 patients. This is the primary outcome is the total volume administered in the first 6 hours. I already told you that in Clover's, that was over 3 liters. And then the secondary outcomes are volume at 24 hours, organ support-free days at 28 days, and 60-day mortality. And this is the protocol. And again, I think that what I want to emphasize here is you give about 1 liter of fluid for a systolic blood pressure of less than 90. And then try to stop monitoring fluid responsiveness. So I think this is a good trial, and it'll be really interesting to see what the results are. So I had told you about this slide a couple of days ago, and unfortunately, this is the state of the art. And I just want to emphasize, well, we know that this is not enough. And we know that this is too much, 6 liters. And this is a joke, of course, but how much is just right? That's the problem. We really don't know. In 2023, we really just don't know what the right amount of fluid is for our patients who present in sepsis with hypotension. And I would love to say we can individualize it, but part of the problem with individualizing it is if you keep checking for volume responsiveness, you'll find that patients are volume responsive. And therefore, you give more and more and more fluids, which I think at a certain point may not be beneficial. And so in conclusion, I'd say that the published data and current guidelines support the idea that when you see someone who's septic and they're hypotensive, give them 30 cc's per kilogram. And finally, published data suggests that fluid overload and positive fluid balance are associated with worse outcomes. And I think the problem is, how much is enough? We really don't know. It's 2023. We've been in critical care for over 50 years now, and we still don't know the best way to hemodynamically monitor someone and how much is enough in terms of fluid. And that's unfortunate. I think it's safe to say that we can safely restrict fluids, and two trials, ours and the Clover's trial, suggest that you can safely restrict fluids as long as you give them 30 cc's per kilogram, which is what they got in Clover's. You can safely restrict the rest of the fluids you give. And with that, I'll say thank you.